what we use, and roll that vertically down.
Right.
The middle of your spine, is it about vertical? It's about vertical there, isn't it? Something about that. If I blow that up now. Oh, don't want to do that, don't do that. I'll just move that, I probably have. No, it's still reasonably vertical. That's the middle of your sacrum.
Right.
That's L5. That's the middle of L5. So the red line is coming roughly down the middle of your pelvis. So your head is lined up with your pelvis. Doesn't matter what your spine's doing in between. Your head's lying up with your pelvis.
Right.
Okay. So the fact that they've got this tilt is sort of it's awkward, but actually it's not something where I have to worry about making a huge difference to the tilt and it throwing you out of balance. Okay?
So that's good news.
Good news for me.
Right.
It doesn't make it a lot easier for you, but it's technically from my point of view, it makes life a little bit easier. We know you've got this narrowing at the bottom of your spine. There's your MRI. I hate this computer. For some reason it likes to pull. So the right side where you get less pain in your leg. This is where the nerves are leaving. So the blue line is on. This is your right hand side. That's your left hand side. So where the nerves leave, that's a nerve leaving. That's a nerve leaving, and it's got white around it. The white is packing material. It's like putting a vase in a box. You put those little polystyrene beads around it. So that's the nerve. You've got white around it, you've got room, so the nerves there can leave without too much trouble. Come across the left hand side, there's no white in there at all to speak of. L5 is not too bad, but there's none of the white in there. You're certainly squashing your L4 nerve root to that point.
So that's where I'm getting the pain from.
I think that's where you get your leg pain from. Okay, and say there's a bit of narrowing around your L5 nerve, S1 nerve root there. That's an easy problem to deal with. There's bits that are easy and bits that are harder. Okay, if the narrowing is in the canal, you can do simple things with a reasonable chance of improving leg symptoms. If the narrowing is where the nerve leaves, simple things generally don't work very well because the narrowing is because it's compressed up down. That black letter V is a ligament humans don't need very much these days. So you can remove the black letter V, you can remove the ligament without affecting the stability or shape of the spine and take the pressure off nerves.
So is that quite a simple process?
That is. The difficulty is you can't do the same there. And this is why we need the X-ray, see how much curve you've got. It also comes down to what you're going to define as a good enough result.
Well, that's kind of what I want to ask you, yes.
Because if you're treating back pain, it's a lot harder to get a good result with back pain and a much bigger procedure. If you're trying to help leg pain and not change back pain, you can usually or sometimes get away with smaller procedures. Okay?
Right.
You can't treat back, you'd automatically treat leg pain if you're treating back pain, but you can try and treat leg pain without treating back pain. So we treat them as separate. Both arise in the spine, not a problem, but called back pain is the wear and tear, leg pain is a trapped nerve. Trapped nerves don't cause back pain. Okay?
So it's nerve pain in my leg. Right?
Nerve pain in your leg and back pain in your back.
Right.
Okay. Natural history. First thing you need to understand is what will happen if you don't do anything, because that puts everything into context. Okay. Don't expect it to put you in a wheelchair. Okay. You've got enough room there. There's enough white there that the nerves should work fine. There's a very small chance that you could lose power in your foot. So pulling your toes up will be hard.
Like Uncle Billy.
Yeah, is that what, a drop foot?
Drop foot, yeah.
Because my brother
Yeah.
has a similar anatomy, and that's what
Chance
happened
of
with him.
that happening acutely, so you wake up and your foot doesn't work or something goes off, is less than 1%. Can happen, can't say it can't, but the chance of it happening acutely is very small. Chance of it developing over a month, couple of months, relatively acutely, that's a few percent, maybe 5%. Chance of it developing over a long period of time, maybe 10, 15, 20%. That sort of order. So it's possible you might get problems with foot control in the longer term, but it's by no means certain. Okay? An acute deterioration where you have to make a lot of decisions very, very quickly, that's very unlikely. Okay? So in terms of the nerves, I don't expect things to change. I don't think they'll improve very quickly. Sometimes nerves just get used to the fact they're squashed, and I think you get used to the pain as well, so the pain isn't as prominent.
Well, this is prominent.
Oh no,
okay.
I think in time, some
Yes,
people find it
yeah.
becomes less of an issue because they've had it so long. It's like limping. If you've limped for 50 years, you stop noticing you're limping. You're still limping, you know. That can happen, but more likely the pain will probably be by and large as it is. Good days and bad days, variability. So I can't see that you're suddenly going to get better and everything will be wonderful. Equally, I don't think you're going to deteriorate rapidly. I think where you are is where life's going to be. Okay.
Really? So
If you don't do anything,
don't do
this
anything.
is.
I don't do
Yeah,
anything.
you've got to put
pretty
everything
much
into the
stays you
context
are.
of doing nothing. What's a natural history? Because if you choose intervention, you need to know the alternatives. Okay? So doing nothing, I think where you are is where you are. You can try and manage it with painkillers. So it's not that doing nothing doesn't mean literally doing nothing. It just means doing nothing other than managing it with painkillers. You can try more injections, but you had a few and they're not working, so I can't see any more of those. Okay? TENS machines, acupuncture, they can help.
I do some acupuncture.
Just to do acupuncture.
How much long-term difference they make,
No, she gets a few days
Yeah.
relief.
it's a bag of frozen peas on swallowing.
Yeah.
That's what I say. Next step up, you've already tried most injections. I can't think there's any more that realistically are going to be useful. Because after that, then you start to talk about operations. Okay, and I said the small operations designed to try and improve leg pain. Normally when you talk about improving leg pain, you're talking about 85-90% chance of relieving pain.
That's good odds.
In you, if you're trying to just do leg pain and keep it a small procedure, you're probably a bit lower because it's slightly harder to get a good decompression without turning it into a big operation. So you're probably looking around about a 70% chance of getting rid of about 70% of your leg pain.
I get rid of 70% of the pain. Is that what you're saying?
Of the
In
leg pain.
of the
Of
leg.
the leg pain, right?
So
If you do the small
if you do a
procedure.
small operation, you get rid of some of the leg pain, or a lot of the leg pain, but not necessarily all of it. Probably won't change your back pain. Okay. That will be basically free the nerve up there and just free it up there as much as we can. So we'd improve the amount of room, but you wouldn't create an excessive amount of room. Okay. It's a small operation that will take you about 6-8 weeks to get over. To get over the bulk of it. Chance of damaging the nerve, 1 in 100. Chance of damaging more than one nerve, a lot less than 1 in 100. Infection risk 1 in 100. I say main thing for small operations is recovery time is relatively quick.
That's what you had before. You've had a previous decompression.
Is that what that is, a
Yeah,
decompression?
you've had a decompression at that level before, so you'd be revising that area.
So you that was relatively fine, wasn't it, to recover from?
Yeah,
Yeah.
so that theory you've had it done before. There's a bit of scar there. You'd try and free that, revise that, and decompress that level. So the intention of improving your leg. Okay, it's a small operation. It doesn't stop you doing a bigger operation later, but because there's a bit more scar tissue, it just makes it a little bit more exciting if you have to do a revision operation later. The alternative is you're looking at decompression and fusion, but you're starting to talk about big surgery. You're starting to talk about potentially even front and back surgery. And what that means is to correct that tilt. I'll go back onto the one, haven't I? Will that at the same time? I don't think it will. Well, good.
When you say front, you mean you're going in
Actually,
From the
probably through the side, to be fair.
The side.
We call it front because it's the front of your spine, although we access it usually through the side. And you've got a disc space there, there. We'd probably try and jack those apart. Now
Right.
you can do it to the side, you can do it all from the back. The actual technicalities of the operation are less important than actually the overall decision making about is that the sort of operation you go down. Okay? Because deformity surgery, to jack the bones apart, you'd have to put screws and rods in, probably put cages in. You're talking a surgery that goes from this big to this big. Okay?
I did manage to make some kind of understanding of the things you gave me to look up on the internet.
Yeah. So you're talking about a big operation. You're talking about a recovery time of 3 to 6 months. Again, it's probably more likely to help your leg pains. We're probably back up to the 85%, 9% chance of really making a big difference to leg pain. Back pain surgery, roughly 1 in 3 people says it was a waste of time, and a good result is we improve you by about 50%.
Oh, really? Only 1 in 3 says it's
1 in 3 says it's a waste of time. 2 out of 3 say it was good.
right.
So yeah, 1 in 3 is a failure. It's a rough idea. Defining it as if people come back saying it wasn't worth it.
Even with the big operation, inserting rods and screws and
Because the difficulty
cages.
we have is saying exactly where pain is from. So if we end up fixing you there to there, it's not to say you can't be getting wear and tear from higher up. And if we do fix you there to there, it puts more strain on those levels that wear out faster. So they can cause pain down the line.
Are you sort of hinting at that it wouldn't be worth
No,
worthwhile
I don't
having a
live with
big
your
operation?
pain.
Pardon?
I don't live with your pain.
No.
And I don't tell people what to do. I've got to give you the information that lets you weigh it up to work out what's right for you. Because I had a problem with my ankle, knackered ligament. I had the option of either having an operation to fix it, with actually they could. It's one of those. It was a technical thing. There's a chance that could have left me a bit worse off in terms of sport. The reason I had it done was just sport. Day job was fine. I could walk. I could run in a straight line on the track, no problem. But playing football, martial arts, the things I do, couldn't do. So either have an operation, wear a brace, would it restrict? I could have done it, but it wouldn't have been the same level. It restricted me, or do something different, find a different sport. Now, all three are reasonable. My brother, who's an engineer, who's not a medic, he said, just do a different sport. You're getting older. You're not going to be doing that forever. Why take risks? You don't have to. So he would either worn a brace or change sport. Me, my personality type is just fix it. I took the risk, it's fine, it's okay.
So you had the operation?
I had the operation, we're fine. But my brother, who's from the same upbringing, would have a completely different approach if it was his problem. We're all different.
Yeah.
So you can't tell people what to do. If one option is dramatically better than the rest, it should be obvious from the way you tell people. If you do this, there's a 90% chance you'll be better. If you do that, there's a 20% chance you'll be better. That's, it should be easy. If there genuinely isn't much difference between them, then you can't say you should have that one done because I like doing that one. Okay.
Yeah.
So it's fairly major surgery for about a 50% chance of it being
Better chance of improving your leg pain,
Yeah.
and it may well help your back pain, but it's not guaranteed to help your back pain.
Right.
Do a little operation. I don't expect it to improve your back pain. Hopefully it will improve your leg pain, but slightly lower chance of doing that.
Right. The scoliosis that's there, has this developed or have I always had
No,
this?
that's mainly degenerate. It's mainly degenerate. There's you possibly might have had a very small curve as an adolescent, but that looks predominantly. There's not much rotation on it. If you got as a child, it rotates. There's a lot of rotation for paediatric.
Yeah, because I didn't know I had. I thought the pain that I had was due to arthritis
It is.
because I'm 75.
Yeah. The shape of your spine doesn't actually matter too much unless you're sticking a knife in it. To be honest.
That's something to think about because I just anticipated having the major operation, but I'd be quite happy if it's a minor, if it's a lesser
I offer it
operation.
because it's an alternative. Looking at your scans, because you're balanced, because your head is above your pelvis, doing a smaller operation, I'm happier that there's a chance that will work. It's not as good a chance, but there's a chance that might work.
Right.
If your head was over here and your pelvis was there, you're out of balance, it won't work. It's only because your head is above your pelvis.
Yeah, and you don't look wonky when you're walking either.
No.
So if you've just fixed your spine where it is, we just fused you where it is, free it up.
Is there the possibility of starting with the decompression and then
You
going
can do
to
a smaller one. If it doesn't work, you can. The downside is it's 2 lots of surgery, it's 2 lots of recovery time, and you'd be revision surgery potentially. So it's, as a surgeon, it doesn't bother me, but I'm not the one who wakes up in the morning with the pain.
Yeah.
Oh. You're just confusing me.
Sorry.
No, I don't.
Apologies.
I'm glad you're telling me all this, but to make a decision is quite.
You don't make any decisions today if you don't want to. You can make a decision and change your mind.
Right.
It's entirely up to you how you do it. It really doesn't make any difference to me.
If she wanted to proceed, timings and costs.
You're not insured, I think, are you?
I'm not insured, so the cost is important.
Well, we're done through the NHS. First thing to say is, unless you tell me to the contrary, people who aren't insured, I will do through the NHS. Because you choose your treatment based on the right treatment for you, not what you can and can't afford. Or choose to pay, or whatever, okay?
Right.
Because I'm wary of people saying, well, I'll have that one because I can afford that one, when it may not be the one that they really want.
Right.
So I'd just like to be honest, look there and say, people self-funders, the default is, unless you tell me to the contrary, we'll do it to the NHS, because that way I know you've picked the best treatment for you. That makes sense?
Yeah. Yes, I appreciate that.
Okay,
but yeah.
Coming back to your question.
The but is how long would I have to
Yeah,
wait?
you'll be P3, following COVID, everything now gets a prioritisation status 1, 2, 3, 4. P1's target time is 72 hours, you ain't that. P2's is 28 days and you're not that. Because it's leg pain, you would officially be called P3, which is a target is 3 months. We're not hitting 3 months, we're not even close to hitting 3 months. But what it means is actually you're not as bad as a P4, which is you can wait over 3 months because they're not getting done for. Current target on those is 75 or 72 weeks. That's what currently hitting for P4s. P3s be down to 45 weeks is my guess.
So
So
about
eight,
9
months.
months.
For this specific one.
Yeah.
So you'd probably be looking around about that time period off the top of my head, NHS.
And you wouldn't do it privately?
I can do it privately, but in terms of cost, a small operation, you're probably looking in the region of 9,000, I think. I don't know because I stay out of that, to be honest. I'd get them to send you formal quotes.
Right.
Okay.
Yeah.
You're probably looking around about 9,000. Big operation, metalwork alone, you're looking just the instrumentation. You're probably looking about 4,000 or 5,000 for the metalwork alone. So the surgery is going to be coming around about 18 to 20 grand to guess.
Quite consideration.
It's a lot of money.
And if she did go privately and paid for it, how long would that wait be?
That's basically the next available list, which usually is no more than 4 weeks is probably about as long as it gets. I've not listed anyone. My next list in 2 weeks, actually, I'm on holiday. I've got a week off. So my next list after that is 4 weeks away. There's only one person on that at the moment.
And are we're talking about major operation here? We're talking
Either.
about either.
Right, well,
Whatever you
major would take a whole session. You need the whole session to yourself, so that will be the first completely free list. I get a list every other week or thereabouts, and they're usually no more than one list full.
And would that be the ROH or here?
No, privately potentially can be done here. You do posterior only, certainly. Anterior they get a bit more touchy about. In fact, the aim is basically jack the bones apart. You can put it through the sides, you can put it through the back. Technical term is we're just doing anterior reconstruction. So a big operation that can be done here. It's the only thing I'm wary of with bigger operations in private hospitals is at night the only person in the building is the RMO, resident medical officer, who usually is an overseas GP, who's not a specialist in anything.
No.
So the backup in a private hospital after big operations isn't as good, if you need to be blunt about it.
No, that's
No,
fair
I
enough. Yeah.
definitely agree with that.
So if you had a cardiac problem, you got some chest pain, RMO would look at you, call me, I'd have to come in, and if you need a cardiologist, I've then got to ring round and find a cardiologist who will come in and see you, who's available and prepared to come in, does private work. Whereas on the NHS, they just ring the on-call cardiologist who's there.
Yeah.
Is there the option of doing the private operation in an NHS hospital?
Yes, it can be, but it takes an awful lot longer because NHS lists are fully booked. So you're looking to find a list, usually on a Saturday, that they will staff.
Yeah.
They've got a private ward, I think. They're actually I'm actually based now at QE.
Right.
They're opening a private hospital in the next few months. We're actually thinking of moving the whole of spines into the private wards. So the NHS ward, but actually the building. So there might be, but
Right.
it's not as easy to do it
No.
in a NHS to private work.
If I were to go for the lesser option, I've got a list of questions here. It was about the scoliosis. I thought it was arthritis, but obviously the scoliosis was developed because of arthritis. Yeah. And just the outcome, and you've explained that. Again, would it relieve the leg pain, and obviously the lesser procedure would.
Lesser procedure aimed at improving leg pain.
Right. And the recovery time from that?
6-8 weeks to be 75% recovered.
Yeah, that'd be similar to what I had
Yeah,
last time.
Yeah.
same procedure you had before.
Right. And the approximate cost of that, you think is about
I think about 9, but I'll get them to send you a quote.
Yeah, okay. Is there anything I can do prior to having this that would, I'm in the process of trying to lose some weight because I've been in steroids for the last 3 years because I've got polymyalgia.
Weight is one of those things. I don't blame weight. I think you get skinny people who have terrible back and leg pain. It won't help the situation. If you're carrying a lot of weight, it won't help your back.
Yeah.
But very seldom is it the sole cause.
Right.
If you can lose a bit of weight, it may help. But I don't want to mislead people and say, you go and lose weight, you'll lose your back pain. It doesn't work like that.
What else have I got here? Just the fact that I have polymyalgia and I still take steroids, not a lot.
1 milligram.
1 milligram a day, so that doesn't interfere in any way.
You need an extra steroid cover perioperatively, so the anaesthetist would need to give some extra steroid because your adrenals probably are a bit switched off.
Before and after?
During the time of surgery, we give you a bit more steroid. It would increase your steroids immediately afterwards.
Right.
Because the stress of surgery, you need more steroids. You're probably not producing very much yourself, so you're relatively steroid dependent. Would increase your steroid for a bit. The other problem with it's certainly relevant to the bigger operation. If you're on steroids, your bone density is often a bit less. So putting screws in, the grip may not be quite as good.
That's something to think about.
So you can
You've not been
cement
on
them in,
high dose. I mean, what was the most you were ever on at one?
20 milligrams.
but it's
But I have been doing it for 3 years.
yeah. So you've been on it a little while. You can cement the screws, and so you put the screws and then inject cement down the middle of the screws, and it comes out of the screws and anchors the screw into the bone. But you're adding on to the complexity. There's a risk of cement leakage that may not cause any problems at all, but very, very occasionally that is an issue. And certainly if it's something that's been done privately, you put another £2,000 on just for the kit for the cement. So the price you start.
Yeah. If I have the lesser procedure, I mean, I haven't played golf for a few years. I'm not that I'm a great golfer, but I do enjoy it. Would I be able to, if I didn't have the back pain, do you think I'd be able to go out and play some golf?
You can play golf tomorrow. It's how much pain it causes. You won't do damage.
really.
Mm.
And likewise, I live up in Aberdeenshire, and there's lots of wonderful walking in that area. And I'm a member of a walking group, but I haven't walked with them because I only get about 200
There's a
yards.
huge
and I
difference
need-
between pain and harm. Okay, so if you decided I'm going to go for a walk and I'm going to walk a mile, and you might drag yourself round there and be really struggling with a lot of pain, you will have pain, but you won't change what's happening on the inside
Right, so
dramatically.
I'm not doing more damage.
So that's really important for you to realise that.
Yeah.
Okay,
Yeah.
so there's an element of the less you do, the weaker the muscles get.
Yeah.
The weaker the muscles get, the less support for the spine, the less support for the spine, the more pain, the less you do, the weaker the round and down spirals.
Yeah, which we've talked about, haven't we?
Yeah.
So
This
it
is
is,
a physio, so
it's,
she's,
you've got to push it.
yeah.
How hard to push, that's the difficult bit.
Yeah.
Well, it's very hard to motivate yourself even when
Yes,
you're,
I call it the cup of tea test.
when you're in pain.
You push to the point where you say, I need a cup of tea. You're not stopped at the first twinge, but we all recognise that point where, okay, yeah, if I grit my teeth, I can do some more, but it's you know you're taking a separate step up, and you actually what you need to do is sit down and have a cup of tea.
I feel that quite regularly.
You function in 3 zones. I draw a lot of things out. Normally, everybody functions in the comfort zone.